Good afternoon. Welcome to today's CME activity. There is no commercial support, and the speakers and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you're viewing online, I will list the link, the evaluation link in the chat section, and if you're viewing after the fact, you can find that evaluation link in the description section of the video. If you have a question for our speaker today, please enter it into the chat. And if you're in the room, we'll wait and ask those at the end with the microphone. It is my pleasure to introduce Dr. Michael Klein. He is a third-year internal medicine resident. He attended undergrad at Florida Atlantic University and St. George's University for medical school. He has an interest in cardiology, and after graduating in June, he will be moving to Phoenix, Arizona to work as a hospitalist at Banner Health System. Join me in welcoming Dr. Klein.
Thank you, Jennifer. Like she said, I'm Dr. Michael Klein, so one of the third-year IM residents here. So I'm going to be talking about burnout and mental health within the healthcare system. So just to begin, I do not have any financial interest or any arrangements with any corporations providing financial support. Get that out of the way. All right, so the objectives for this presentation, the biggest thing is to understand the prevalence and the diagnosis of burnout and depression within the healthcare community. Second is to raise awareness of the factors that contribute to worsening burnout and depression, and then discuss some of the means to combat burnout. So this is the outline for this presentation. So go through the definition, theory. Big part of this is the Maslow burnout inventory, which I'm going to have all of you do individually. Talk about burnout within healthcare, rates of depression, suicide, costs that are accumulated as a result of burnout, coping, outcomes, solutions, and then you can see all the references. So burnout was originally described in the 1970s by psychoanalyst Freudenberger. It's actually listed in the ICD-11 as an occupational phenomenon, so it's not an actual diagnosis, but it is a recognized symptomatology. So the World Health Organization has a definition for it, and they describe it as burnout as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed, and that's whether in the system or by the individual themselves. So the way that we measure burnout is actually by there was a follow-up to Freudenberger by Christina Maslach, who came up with the Maslach burnout inventory. There's a couple different forms of this, but there's one specific to medical personnel, and that's the MBI-MP. So they described it as 3 qualitative dimensions that are required to sort of categorize this, and we'll go through those individually. But the 3 main points are feelings of energy depletion or exhaustion, increased mental distance from one's job, or feeling of negativism or cynicism related to one's job, and then reduced professional efficiency. So this was the original 12 steps that was described by Freudenberger, and then it sort of evolved once Maslow made her own interpretation of it. And this is a continuous cycle. It's not you start at 1 and then you get to 12 and then you stay at 12. So first is when someone goes into the workplace, specifically the healthcare system, they have a compulsion to prove themselves. They're very sort of motivated. 2 is they start working harder. 3 is they start neglecting their own needs. 4 is they display some of their conflicts and needs. They just repress it. 5 is revision of their values. They start saying, oh, I don't need something that I thought before was a core of their own self. 6, denial of the problems. 7, then they start to withdraw. 8, obvious behavioral changes. And 9, depersonalization. 10, inner emptiness. And then they go into depression. And then they go into that full burnout syndrome. Now, it doesn't stop there. A lot of people will sometimes have a small form of recovery, and then they'll feel that they're no longer burned out, but they're not quite back to where they started. And that's where you have that sort of cynicism that we're trying to prevent. And then you go right back into the cycle. So you recover a little, and then you feel the compulsion to prove oneself, and then you go right back into the cycle. And each time it's sort of a stepwise sort of decrease of where you started from. So the next part is the Maslow inventory. So I want to take a couple minutes on each of these slides. There's 3 sections. I want you to either on your phone or on a piece of paper to take a mental note of what your own score would be. And before we do this, has anyone at any point felt that they've been burnt out within the healthcare system? So a lot of people here, and you'll see that the statistics follow that. So we'll go through this in each one step by step, and I want you all to actually sort of calculate it for yourself. And this will become important with your score later in the presentation. So the first part is the burnout section. So first question, I feel emotionally drained by my work, and that's whether it's never, a few days a year, once a month, a few times per month, once a week, a few times per week, or every day. And the higher the scores, clearly the worst, sort of the worst scores for burnout. So make sure that you're following this, okay? Second is working with people all day long require a great deal of effort. I feel like my work is breaking me down. I feel frustrated by my work. I feel I work too hard at my job. It stresses me out too much to work in direct contact with people, and I feel like I'm at my end's rope. And in healthcare, you're going to be either seeing patients, taking care of patients, dealing with their families, as well as your colleagues. So all of this applies to each of these individuals. So, okay. All right, so tally up your score and keep a mental note of it. Second is the depersonalization. So same sort of score system, but we get, I feel I look after certain patients or clients impersonally as if they are objects. I feel tired when I get up in the morning and have to face another day at work. I have the impression that my patients, clients make me responsible for some of their problems. I am at the end of my patience at the end of my workday. I really don't care about what happens to some of my patients or clients. I have become more insensitive to people since I've been working. And I'm afraid that this job is making me uncaring. And those last 3 are very important, and that comes up later. So you have a tally of your score? All right. And then third is personal achievements. So I accomplished many worthwhile things in my job, and this is sort of the opposite. I feel full of energy. I am easily able to understand my patients and my clients feel. I look after my patient client's problem very effectively. In my work, I handle emotional problems very calmly. And through my work, I feel that I have a positive influence on people. I'm easily able to create a relaxed atmosphere with my patients or clients, and I feel refreshed when I have been close to my patients or clients at work. So these 3 sections are what determine your score. So that brings us into the actual scoring. So for your burnout section, you really want to be scoring low on these. So those lower numbers, the zeros, where you rarely have any of those symptoms of burnout. So if you're 17 or less, you have a low level of burnout. Between 18 and 29 is moderate, and then above 30 is high. Then depersonalization, so you want a lower score, so total less than 5 is low level, 6 to 11 is moderate, 12 or greater is high, and then personal achievement, you want higher scores. So 33 or less is high level of burnout, 34 to 39 is moderate, and then 40 and up is low level. So I want you to keep a note of each one of these and then sort of put it in perspective of if you're meeting the criteria for burnout. So this is Maslow's sort of interpretation of those 12 stages that was first described by Freudenberger. So this is the employee burnout. You start, you're doing very well within the healthcare system. You're happy to be there. You have high productivity, high job satisfaction. You're optimistic. And then you have sustained engagement. And then the factors of stress sort of weigh on you. And then you become less productive. You have less social engagement. You have poor attention, avoidance or irritability, focus or sleep disturbances. And that's short term. Then as those continue to play a role, you go into that chronic stress phase. So then you have that absenteeism, apathic or resentful attitude, aggressive behavior, chronic exhaustion, and then you start getting cardiovascular symptoms like tachycardia, and then a lot of people get palpitations just from the chronic stress, and then you go into that fourth stage of the burnout phase. And that's where you have difficulty maintaining personal relationships, obsession with stressors, digestive issues, escapist behaviors, increased drug and alcohol consumption. And then 5 is that chronic burnout, where you go into chronic depression and anxiety, social isolation, chronic physical pain, emotional fatigue, drug and alcohol abuse. So this is just an example of over the last couple years. So COVID was a big factor that led to a lot of our healthcare colleagues experience burnout and going into phases of depression. So this is just over the last couple years, but it's just an article to sort of give you an example of how bad it's been. So in the Journal of General Internal Medicine back in March 23rd of 2023, they surveyed 43,000 healthcare workers. So this was based on 35% of them were physicians, 25.7 were nurses, 13.3 were other clinical staff. So that includes pharmacists, nursing assistants, respiratory therapists, physical therapists, occupational, speech, medical assistants, and social work. And then there was 25.8 were the non-clinical staff. So that's like housekeeping, administrative, receptionists, financial technicians, food service staff. So it's a pretty large study. So back in 23, 49.9% of all the people surveyed reported symptoms that were consistent with burnout, and it had a p-value of less than 0.001. So it was statistically relevant. The rates of burnout were actually pretty surprising. So 56% of nurses described having symptoms of burnout, 54% of other clinical staff, 47.3 of physicians, and then 45.6 of the non-clinical staff. So having those symptoms of burnout, we can see that we would expect that they would have decreased productivity within the healthcare system. But one of the biggest problems is we also saw sort of a mass exodus from the healthcare system itself. So in these same people that they surveyed about their symptoms of burnout, they also asked about their intention to leave healthcare completely. And when they surveyed that, 28.7% of those people surveyed said that they planned on leaving the entire healthcare system. And that was the highest in nurses. So 41% of nurses, 32.6% of non-clinical staff, 32.1% of clinical staff, and 24.3% of physicians felt they were going to leave the healthcare system. There's some, sort of explanations for those percentages. It's sort of theorized that the reason the physicians is the lowest is just because it's been the longest amount of time to get into the healthcare system, and it carries a lot of time and debt, and you're sort of more limited on what you can do after you leave the healthcare system. And the top thing that came up was that they felt that work overload significantly was associated with burnout, with an adjusted risk ratio of 2.21 up to 2.9. And then these are just the studies on the side, and you can see the breakdown, and I'll have the references at the end if you want to look at those individually. So that first one was just during the COVID pandemic, so the previous 3 years. But there's a lot of studies before that were looking at how prevalent burnout was. So this is actually just for a couple different types of people within the healthcare system. So first one, this was a 2006 study. And the reason these are all older, it's actually surprising. There's not many studies outside of physicians that talk about burnout. So that is limited. The ones on physicians are pretty robust and are statistically relevant, but the people who are not physicians within the healthcare system, it's not really well studied. So there was at least one in 2006. This is actually for first year residents. So at the beginning of the year, starting their residency, 4.3% met the criteria based off the Maslow scale of meeting burnout. And then at the end of that first year, 55.3% met the criteria. And that's just in the first year alone. Then in a 2002 study from Washington, this was only 115 residents. This was within their residency, but 76% of the internal medicine residents, regardless of the training year, met criteria for burnout. Another study, 2002, of 415 residencies, including 4,128 residents, 61% admitted to becoming more cynical and 23% admitted to becoming less humanistic during their medical training. So that's pretty significant when you're considering these people are also taking care of, patients and potentially your loved ones. And then in a 2004 study in the Journal of Psychiatry, the average rate of burnout between these different specialties was 50%, the highest being in OBGYN. So that was 75%, and you can see as it goes down. Now, this was for residency. You can see all of these are old. There really hasn't been any major studies within the last 10, 15 years on how this has changed. And there's been a lot of rule changes for residencies, like changes in work hour limitations, but there's really no follow-up on it. But there was a study in 2022, and this is actually on medical students. So this is 26,824 students. And for those who haven't gone through medical school, just as a background, medical school is 4 years. You do 2 years, it's usually like classroom learning, and then you have some hospital rotations. And then the second 2 years is 2 years of clinical rotations throughout hospitals and outpatient clinic. So when they surveyed these medical students, they gave them the same Maslow index. 37.23% were already showing evidence of burnout. And that goes back to that first study. So you have people before they're even actively, working within the healthcare system. So they're treating patients, they're helping, but they're still under that learning guise. And then they go into residency. A huge portion of them are already showing up with signs and symptoms of burnout. And then that goes back to that 2006 study where you do have some time off between medical school and starting residency, and maybe they have some form of recovery, but just like that first Freudenberger's cycle, they were probably at that point of burnout, and then they had a period where they had maybe some form of recovery, and then they go right back in that cycle, and then they're more prone to becoming burnt out. And that, there's not a study for that, but that's likely also what's happening when you're going from residency into attendingship or going and becoming a fellow. So these are some, like I said, the last studies were on medical students and residents, and then all the more consistent studies have been in physicians. Medscape does a survey every year. Some of you may have participated in it, and these are all sort of voluntary studies, but they do have a pretty large survey value. So in 2024, they had 9,226 physicians. 49% reported burnout and 20% reported depression. 2023, it was slightly higher at 53% and 23%. That's potential from COVID, where we did see a spike in those rates and more people leaving the healthcare system. And then before COVID happened, you can see of 15,000 plus physicians, 42% reported burnout and 15% depression. And I added 2015 and 2013 just for reference, that you can see that these values are increasing. Now, of the physicians that were surveyed, we did see that there was a higher rate of burnout among female physicians rather than their male counterparts. So this is just a depiction of that, showing that you can see that the rates have been steadily climbing, and then after COVID, it sort of peaked and then sort of came down after things maybe settled out. So just as a comparison, these are the different specialties and how they sort of surveyed their rates of burnouts. So you can see back in 2018, the highest was critical care, neurology, family medicine, OBGYN, internal, and so forth. And then 2024, you can see emergency medicine had a significant jump in their rates of burnout, all the way up to 63%. And that's also a possibility as a result of COVID. But you can see OBGYN still stays very high towards the top, but then oncology surprisingly went up. And then And then you can see as it goes from there. So when they surveyed these same doctors, they asked what were the contributing factors that led to their burnout. And the number one thing was too many bureaucratic tasks. And then second to that is something that we have, the ability to change our work culture, is that there was a lack of respect from coworkers. And then it goes down from too many work hours, insufficient compensation, lack of control or autonomy, computerization practices. So EHRs end up spending a lot, maybe 30-40% of our day is just working on notes or different charting. And then government regulations, stress from COVID patients, and then other. And then, so I'll touch back on that lack of respect from coworkers later in the presentation. And then if we break it down by where the highest rates of burnouts are, we're actually seeing in these outpatient clinics was the highest. So 57%, and then tied to that, but it was actually a little less. It's just within that 57% was office-based multi-specialty groups, and then healthcare organizations, hospitals was 55%, academics, and then office-based single specialty practice, and then office-based solo practice, which was actually the lowest burnout, and that's sort of thought to be as a result of increased levels of autonomy. So they have more control over their day, their practice, their patients, whereas in some of these other groups, you really don't have control over that. So besides burnout, we also want to talk about depression. So these are also from those Medscape surveys, and this has been stable over the last couple of years. But this is breaking it down into people who have signs and symptoms of depression or have been clinically sort of diagnosed as depressed. So colloquial depression, feeling down, blue or sad, was 67% of the physicians who have had depression. And then clinical depression, where they're actually getting treatment or they're having those lasting effects, including severe depression, not caused by a normal grief event, were 24%. And then some of the other things that they didn't really answer. And then the factors that contribute to their depression, the number one thing that people were surveyed for was job burnout, was leading them to become clinically depressed. And then second is responsibilities, finances, world events, family issues. But you can see that those really sort of decreased, where that job burnout is 72%. So very significant. So we're looking at burnout, we're looking at depression, but why should we care? So first things first, you get lower quality of care for the patients. So people become more of a cynic, they stop caring about their patients' needs. And then you get reduced patient satisfaction. You actually have more medical errors, so it's associated with higher morbidity and mortality for your patients. There's increased medical malpractice claims, increased cost to the patients themselves. And then we should absolutely care about the healthcare workers' well-being. And then this is just a scale of how severe people's burnout are. So you can see this is more just to show you that the rates have been higher in women than their male counterparts. So when they asked what is their depression doing to their patient relationships, we can see that maybe the doctors themselves are, or any of the healthcare workers, but this is specific to doctors, are no longer sort of as empathetic. Some of the doctors, 40% said they get easily exasperated with their patients, so they're more short-tempered. It says, I am less careful with patient notes, so there's more medical errors. I express frustration in front of my patients, make uncharacteristic errors, and my interactions are ineffective is only 45%. So when we're looking at medical errors, there was a 2010 survey, and this goes back to the Maslow burnout inventory, is that in 2010, they measured the MBIs of 7,905 surgeons. And they found that just 1 point increase in that depersonalization resulted in 11% increase in medical errors. And then 1 point in emotional exhaustion correlated with 5% increase in medical errors. So if you consider, if you tracked what your scores were for the MBI at the beginning of the presentation, just think how high it is, or if you're meeting that criteria for burnout, then if you were to change one of those by just 1 point, you could potentially be causing your patients a lot of harm. And then there was a 2018 study of greater than 6,800 physicians that found physicians experiencing burnout were 2.2 times more likely to lead to medical errors. And that includes choice of drugs, treatments, medical notes. And then we have another meta-analysis from 2022 that was 20,000. And that you can see these are all the individual studies that they reference, but you can see that the odd ratios do not cross 1, so they were statistically relevant. Now, with these medical errors, we also have the cost to the healthcare system itself. So the ACP in 2019 did a study, and they approximated that $4.6 billion in costs related to physician turnouts and reduced clinical hours is attributed to burnout each year in the US, and that ranged from 2.6 to 6.3 billion. Now, this is specific to primary care, but their turnover alone led to 979 million in annual excess healthcare spending across the US population, and that was a third of that was attributed to burnout. So for the patients themselves, Medicare estimated that they spent an additional $189 in their first year after losing their primary care physician. And that's because they have to go to a new doctor. They have more visits where they're learning the patient, and then it leads to more referrals to other subspecialties. So the cost of the patient continues to go up. And then for non-Medicare patients, they end up spending $61 more per year. And then in Stanford did a study for 2018 that they estimated that if a practice or a healthcare system loses one physician, then their cost to replace that physician can be $250,000 to $1 million. So that includes the onboarding process of recruiting, flying them out there, them also sort of learning the system, the time that that physician had left that they're not seeing patients, and now for the new physician, either to learn the system, become efficient within that system, or also to build a new patient sort of census if they're in an outpatient setting. And then, so that was just for the physician, but also the loss of sort of the same criteria, but the loss of each nurse was attributed to about $40,000 to replace them. And that's the same thing where you have a lot of costs associated with recruiting and then becoming productive within the system. So this is important because we're having physicians and other healthcare workers leave the healthcare system. And the U.S. General actually projected that there are nearly 140,000 shortage of physicians by 2033, and there will be a shortage of 3 million non-physicians by the time we get to 2028. And that's worsened by people leaving the healthcare system and not coming back. So one of the problems with this burnout and depression within the healthcare system is we're seeing sort of negative coping mechanisms among healthcare workers. Now this graph on the right is specific to the doctors, so this is also from Medscape. But you can see some doctors have good coping mechanisms. So you can see people resort to exercise, talking with their family, they sleep it off, spend time alone, listen to music. But then there's some negative sort of coping mechanisms. So people resort to eating junk food, drinking alcohol, abusing prescription medications, or even illicit substances. So you can see on the left that among physicians within the healthcare system, there's actually a rate of 10 to 15% of substance abuse. And that's even higher with nursing, so 14 to 20%, which is pretty significant. And then this is a study about substance abuse. This was from ACP in 2023, where we had healthcare workers and non-healthcare workers. So 176,000 healthcare workers and 1.6 million non-healthcare workers between 2008 to 2009. So we actually see the rate of drug overdose per 100,000 persons is actually one of the highest among healthcare workers over the general population. So we saw a confidence interval of 15.5 for social or behavioral health workers. Social and behavioral health workers had an adjusted risk of 2.55 times the general population. Registered nurses were 2.22 times. Healthcare support were 1.6. Physicians were actually lower at 0.61. And then healthcare workers, as a combined, when you average those physicians in, actually becomes less than 1, so it was only 0.93. But if you exclude them, those non-physician healthcare workers within our system, the rates of drug overdose are actually significantly higher than the general population. So some of the reasons one of the main reasons that they sort of theorize is just access to medications, but that's something to consider. So besides unintentional drug overdose, we have intentional suicide. So this is a study from the suicide risk in healthcare workers that was published in JAMA in September 2023. This was that same sort of time period where you had 2008 to 2019, where they reviewed 1.8 million healthcare workers, and this is the survey and death index records. So among healthcare workers overall, there was a adjusted rate of 1.32 times the general population for suicide. And you can see that the confidence interval is greater than 1. So it was statistically relevant. Healthcare support workers were even higher at 1.81. Registered nurses were 1.64. Health technicians were 1.39, and that was still greater than 1. And then the physicians was not statistically relevant because of the confidence interval, but the adjusted was 1.11. But you can see that the rates of suicide are greater than the general population. So this is that study, and this just breaks it down. So they'll be providing the recording if you want to look at it individually, but you can see on the side where you have that adjusted hazard ratio, you can see quite a few of the studies are greater than that 1. So you can see that those were the ones that are statistically relevant and showing which workers fell into those categories. So besides coping, some of the other stuff that physicians or other healthcare workers are doing is therapy, which is one of the most important sort of tools that we have to help combat sort of the depression as a result of burnout. The problem is when they survey these doctors about their views on going to survey or going to therapy, you can see 21% felt that they considered their depression to be a weakness. They didn't want to talk about being depressed. They thought that if they were vocal about their depression, it would look negative about them personally. They thought people would think less of them. Thought people might doubt their abilities as a physician, so that they may not have the tools to mitigate their own depression, or that a lot of people were scared that the medical board or their employer would find out. So this actually drives a lot of people away from seeking professional help. And then you can see that the stance, this sort of the number of people, the percentages that recognize that they're having burnout, having depression, or that they would seek medical help. And if anyone here is in psychiatry, you guys are winning on this one. Of all the healthcare specialties, psychiatry is the most likely to seek professional help for their symptoms of burnout or depression. And then we actually saw the lowest rates were among surgical specialties. And that's sort of covered under this right graph, is that a lot of people within the surgical professions felt that there would be more stigmatism against them being vocal about their depression among their surgical colleagues than people in the traditional medical specialties. So besides therapy, there are some programs that are designed to help combat depression, as well as to help combat symptoms of burnout. So this is back in 2023 or 2003 was the National Institute. The NIOSH was developed to help with these symptoms because we were seeing a lot of people were suffering from depression or they were leaving the healthcare system. So they did make a campaign called the Impact Wellbeing Campaign. And then there's the Total Workers Health, and then the NIOSH Worker Wellbeing Questionnaire. Based off this, they designate certain quantities of money to different healthcare systems that are at need of additional funding to promote sort of programs to prevent further burnout and further depression. So there was actually one recently that was the United Health Foundation. They provided a 3-year, $3.1 million grant with the American Nurses Foundation to fight nurses burnout. So they actually have a pilot program where you can sign up for it if you're a nurse and you're feeling symptoms of this. And it's actually it's like a computer program that you can go through. It talks to you about means to help prevent further depression, or how to discuss with your healthcare system on sort of changes within the system to help other nurses. And then there's a larger one. This was for the Health Workforce Resiliency Award. This was in 2022. So this was at sort of the height of COVID, when we're seeing so many people leaving the healthcare system. And this came out to 103 million. But they awarded 68 million to 34 grantees for health and public safety workforce resiliency training. And then for promoting resilience and mental health among professional workforce program was 28 million to 10 grantees, and then 5.9 for public health safety workforce for technical assistance. So of all these, one of the largest recipients was actually our colleagues over at Emory, received a large grant to try to help promote programs to prevent further burnout and depression within their system. And that actually was brought up because they were seeing some of the highest rates among healthcare systems. So most of these grantees were because they were having deficiencies within their system, or they were seeing just higher rates of depression or burnout. So this is actually, these are resources that are from that NIOSH. So they're different call lines. So if you want, you can take a picture of it just to have them on hand. But these are different government agencies that provide free sort of call assistance, whether it's their like crisis text line, they have a veterans line, they have the suicide prevention line. All of these are free, and they're provided for, and they have ones that are specific to healthcare workers. These actually have, some of these lines are run by volunteer psychiatrists and psychologists who donate some of their time to help talk with people who are feeling, either urged to commit suicide or to substance abuse, or they're just needing someone to talk to about their symptoms of burnout or depression. So if you want to take a picture of this, because it's a very good resource. So for this presentation, we talked really about burnout and depression, but the takeaways that I want you to leave here with is that burnout is a genuine issue that impacts healthcare worker well-being and patient care. So you can see the costs associated with it. Rates of burnout have been increasing. And this is for your own self-reflection, is when you scored yourself on that MBI test, that we see even small incremental changes in your score equates to large increases in medical errors. So it's something that you have to sort of, screen yourself for, because there really isn't too many great resources for most systems to sort of combat it. A lot of this is left up to the individual healthcare worker themselves. And that suicide and substance abuse is more prevalent than expected. It's higher than the general population. And this is for anyone who has their own practice, or anyone who has some pull, is that the cost to replace these healthcare workers is estimated to be 2 to 5 times their salary. So there's a lot less cost in creating these programs to help these healthcare workers before they get to the point of burnout or depression than it is for them to leave the healthcare system, and then you have to go through the cost and recruiting and training of getting a new person to replace them for that position. And then that there are resources and people to talk to if you are feeling depressed or burnt out. So for this presentation, I really want to thank the CME team for help hosting this, as well as want to thank Dr. Gross, who I know is listening online. He provided a lot of great feedback for this, and I really appreciated his help. And then these are some of the references. If you want to look at them, you can see them through the video and the link that they provided. And that's the end of my presentation. Anyone have any questions?
Excellent. Thank you, Dr. Klein. We'll remind you, if you have a question and you're viewing online, please enter in the Q&A chat and we'll ask for you. Any questions or comments in the room?
Yeah, one thing that I kind of didn't see emphasis on is a degree of insomnia that precedes the depression and the abnormalities of the function of these individuals. And you see it in stressful situations more and more. The other thing is because of the time you occupy during your residency or being at work, you don't have a tendency to go out and exercise. So sedentary life is always there along with insomnia. And like you said, the junk food that you eat, which is harmful to your brain more than anything else. And New England Journal of Medicine, I remember reading 5 years back that they were also using hyperbaric oxygen for these individuals and treat depression, and they got good results.
So that is interesting. That the insomnia is a big part of this. You can see it in those 5 stages by Maslow, where you do see those changes in personality, you see changes in those coping mechanisms. So we do see a big increase of insomnia. It just wasn't something that was outright surveyed among these physicians. So it's hard to say what the rates or how it's contributing to the burnout. But I do think it's a very important factor. And then in terms of the hyperbaric oxygen, it's very interesting. That would come down to, I think, more funding to help prevent burnout and depression within the healthcare system. That maybe it is an option, but it certainly costly to implement.
Excellent. Any other questions or comments? Let's see, I think we have one come in online. In the process of applying for hospitalist jobs, did you notice that hospitals are advertising their wellness initiatives as a selling point? And what were different initiatives or wellness factors that should be considered both for residents and attendings?
So that is interesting. Going through the whole hospice application process, I mean, I directly interviewed with over 20 programs and at least reviewed hundreds of other different programs. I don't think it ever came up that any of them actually had an active program to help with sort of these issues, like the healthcare well-being. When you talk to them, a lot of them will sort of bring up that some of your colleagues get together and they have fun outings, but really there's no advertised direct programs for helping with these issues, at least none that I saw. Was the second part of the question?
And the second part of the question is, and what, let's see, what wellness factors would you be considered both for residents and attendings? Do you have any ideas of what could be implemented?
Sure. So it's tough. A lot of this comes down, the big thing that when they surveyed that are leading to burnout comes down to work hours. And then sort of the second was the respect from people's colleagues. So one is just having people get together, have time outside of the healthcare system, be able to sort of blow off steam and have that sort of collegial get together just where everybody can sort of express how they're feeling. There was one thing that I was reading about nursing programs where they just had sort of these basically get together sessions where people were just able to outright share their feelings anonymously. So they were sort of, they were call-in sessions where nobody was identified and people were just able to just talk it through without any sort of fear of consequence or retaliation. And the people who did those sessions expressed a very significant improvement in their feelings about how other people are responding, or just hearing other people that are having likewise sort of symptoms, just having that sort of community. So that's something that could be set up between residents and attendings, just to help sort of increase their bond and their sort of self-expression.
Excellent. You got some.
Thank you for sharing this. This was really important. And I think sometimes we can be really cerebral and miss some of the components that are foundational. I appreciate how you brought up the impact that burnout has in the health system and patient care. And I think it was hinted to how the burnout affects people outside of work as well. So I think it really becomes cyclical. You're burned out at work, and that transfers into your drive home, your time with your family, and then that circles back around when you go back to work and you've had a rough time at home. So thank you for bringing up this important topic, and I think it's something that is so valuable. And I hear a lot of residents when they're interviewing for a spot in our program that is one of the questions they're asking now is, tell me about the health and wellness program you have for residents. So thank you.
Absolutely. Thank you.
I think we have one more question in the room, but we had one online. Outside of cost, do you foresee any kinds of barriers to adopting wellness initiatives that could positively impact healthcare workers?
So I don't think that one of the things is cost. So there is a lot of cost associated with creating these programs, but a big part of it is time. So having people willing to sort of, donate some of their time to helping create these programs, and then also designating time for people to be able to get together and, have those sort of experiences together. I don't think cost is the only limitation. Some of it is, when people are burnt out, they don't feel they really have any more time to spare that they can involve themselves in any of these programs. So a healthcare system separating sort of chunks of time for people, designated time outside of their workday to go and have these sort of sessions, I think would be a very helpful option.
I agree.
Hey, Dr. Klein, good job on the presentation, very thorough. In your research, did you find a comparison between like US healthcare compared to European or other countries? Do they experience the same rates of burnout?
So that was actually interesting. There really wasn't a direct comparison between the two, but if you look at them individually, the rate of burnout within the European countries was lower than the US, but then there are factors that were contributing to their burnout were actually different. So in the US, the biggest thing that led to burnout was time. So the amount of hours worked, the patient loads, whereas in a lot of the European countries, they were saying that their amount of hours are generally less than the US, and they're not seeing as many patients, so that wasn't contributing as much. But then from their side, it was more of financial insecurity that was leading a lot more to their burnout rate. So there wasn't a direct comparison, but the overall rates were higher in the US. The reasons for it are different.
Awesome. Thank you, Dr. Klein.
Thank you. Thank you, everybody, for coming.